We're now going to move on to the first panel. I think we should have those slides up as well. And for the session 4. If there are any questions, I would be happy to answer them in the meantime. Okay, so let's move over to session 4, which is the role of colleges and academic medical centers and hospitals in global surgery. And when we enter this panel discussion, we need to bear in mind key messages 1 and 2. Key message 1, 5 billion people right now cannot access safe surgery we needed. And we need to produce 143 million more procedures. It's almost a doubling or 50% more than we are doing today. So how can high-income countries' surgical anesthesiologists, academic medical centers and hospitals help improve surgical care around the world? And especially perhaps thinking about along these terms, workforce and training, healthcare delivery and management, information management and research. This is a nice quote from Nobajit Roy, he's a surgeon and trauma surgeon in Mumbai. He was the lead of the management working group, and he said, teach a man to fish, etc. But why don't you just come fishing with us and see what happens? That was he's a wonderful man, and bear that quote in mind. The moderator for this panel will be my friend and colleague Andy Leather, who is the consultant. He's a consultant surgeon at King's Hospital in London, and he's also the director of their Center for Global Health. So he has a long background in health system strengthening academic work, and especially in Sierra Leone and Ethiopia and Somaliland, and has been key in their work with the Ebola response, for example. He is a co-chair of the commission. Thank you, Andy. On the panelists, we have Fizan Abdullah, who is a consultant pediatric surgeon at Johns Hopkins University. He has an MD and PhD from Jefferson Medical College. He's associate professor at Bloomberg School of Public Health and the program director for the fellowship in pediatric surgery. He has directed health system strengthening in West Africa, mainly, and is the chair of the executive committee of the G4 Alliance. Robert Riviello, another panelist of ours, who's a consultant, acute care and burn surgeon here at the Brigham, director of global surgery programs at the Center for Surgery and Public Health here. And he is particularly interested in workforce aspects and has been spearheading the Boston aspect of the Rwandan HRH program. So Robert Riviello, very experienced. And we have Gary Gottlieb, who's a professor of psychiatry at Harvard Medical School and a member of the Institute of Medicine of the National Academics, and former president and CEO of Partners Healthcare here in Boston, and holds an MBA from Wharton, and currently the CEO of Partners in Health. And then we have Professor David Hoyt, who is a professor of surgery at the University of California, Irvine, who is the past president of American Association for the Surgery of Trauma, and author of many publications, editorial board member of 6 academic journals, and awarded. He's the executive director for the American College of Surgeons since 2010. And then we have Vanda Amado, who unfortunately her plane was too late, so she will not be able to come. She's a pediatric surgeon from Maputo Central Hospital in Mozambique. Many pediatric surgeons on board, I'm glad. She's a co-investigator of the Medical Education Partnership Initiative and a professor of surgery as well. So thank you very much for this long introduction, and Andy, take it away. This is
okay. Thanks, Lars. Good morning, everyone. Last week was great, but it's lovely not to be organizing, to relax and enjoy and learn, as I'm hoping to learn a lot from these panel discussions. So I'm sure you've all been avidly reading the report since it came out last week, and none of that was new, but there's a lot of information there. And for those of us who've been involved for the last 2 years, it's still, you get bombarded by information. But a lot to unpack in this panel discussion. and I'm looking forward to that. But this is also an opportunity for you to engage and ask questions. So keep a close eye on this, because we've got these 4 experts, but I think when the orange goes, it's your turn. So, you know, start throwing things at me, waving, so that you can ask your questions. And please, we want to have engagement from the audience and some really, to make the most out of this session. I want to learn. I'm sure we will. So we're thinking about the role of the college. We're thinking about the role of the academic medical center. We're thinking about the role of hospitals. Some hospitals aren't strongly connected to an academic center, at least they're not in the UK. So what is the role of all these institutions? And there are others, or federations, or specialty associations, all wanting to engage in global surgery and play a role. But let's start with the role of the college. It's really interesting. We have so many colleges. We've got a Glasgow College, an Edinburgh College, an Irish College, a London College. And what's fascinating is they all want to know how to engage. I've had 3 presidents on the phone or Skyping in the last few days since the commission came out. So that's interesting. So we want to learn. David, what is the role of the North American colleges? And perhaps, you know, with your role at the American College particularly, what are colleges doing, and what can they do to promote, to sort of seriously engage with colleges across the world to promote surgical training? So what is your view?
Well, I'd like to start out by just thanking you all for the opportunity to be here, and I'd like to thank John and Lars and you, Andy, for doing this. I think, you know, this is really an important day. What this report is going to do for us is it gives us language to describe the message for the first time. And not for the first time, but it gives precision, and it gives numbers, and it gives a way to tell this story in a very compelling manner. And people are going to be able to get their arms around it and start to want to be a part of solving it. I think, you know, as we think about how members of the college, which are really practicing surgeons, but all the way from residents, we think about the trajectory of a surgeon. And you start as a student, you go through training, you go into practice, and there's an early point at which you're interested in giving back. And then as you get deeper into practice, there's a time when you start to mentor and you're interested in giving back toward the end of your career. So if that is an opportunity, then what I think the colleges need to do in working together, and what I think we need to do to take a report like you all have created to really actualize it, are several things. First of all, we need to create the opportunities for people to serve. And you know, just 2 weeks ago, we had an earthquake, and we have a mechanism for signing people up who want to serve. What we didn't have is an opportunity to couple them with an opportunity. And in fact, many that went over to serve did not find anything to do. So that's a disaster response, but similar to this challenge, we need to find a way that has the structure that can be identifiable to people so we can then promote opportunities for them to serve. I think the second thing in my mind is we need to create a culture of service. You know, particularly in academic, I spent my life in academic medical centers. Contributing other than to basic science or other fundamental ways to give back are not rewarded the same way academic careers have traditionally been rewarded. So creating a culture of service that really allows people to take time off of their practice, allows partners to be willing to cover for them, that kind of thing. I know that seems like a very simple thing, but it's really fundamental. And learning how to practice better as teams, as professionals, I think will enable the opportunity for people to serve. To me, the third one is important as well, and it's, I guess, intuitive, but somehow as we create these opportunities, we also have to create systems of continuity to assure quality and safety, because many people are particularly in high-income countries, are used to that kind of continuity, and we've got to have that same sort of established safety culture when we move into an environment where we're really just serving. Now, our college right now has a lot of things we're trying to work on. We're trying to collaborate with other colleges specifically to meet some of these questions and needs. We have a program called Operation Give Back. Gurma Tafura is here. Hopefully you can meet him. He's the medical director of that. He is developing programs specifically for opportunities for our fellows to be able to do that. And we have a lot to give in colleges. I mean, just think about the applicability of the concepts of a trauma system to developing systems in other areas of the world. And that's experience. We have, virtually every academic medical center in the country who are currently teaching residents. I mean, we have that as a resource that could be used to help set up schools or training programs, et cetera. And it goes on and on. I think the last thing that I would mention that we really need to think about collaborating on is what I'll call the electric infrastructure. There's so much today that can be taught through the internet, and that is something that can be deployed. When you look at it, I don't know if you saw this thing with Telsa, the company that's created the electric car. They've just created a battery system that can be charged with solar power. So suddenly electricity can be deployed into areas that perhaps there's not traditionally been the infrastructure. And I think the ability to learn how to use electronic teaching mechanisms can really help this as well. So those are three areas that we'd be very interested in collaborating in.
Great. Thank you, David. I've got a whole lot of things I've got to ask. It's coming back on that, but I want to come to, for you all to have an opportunity to address questions. So I get to there before the orange light goes on. But we might come back to some of those issues you've raised in just a moment. Fizan, the Academic Medical Centre. In London, I'm really always pushing King's to do more. And so I'm really interested in your view of the role of the Academic Medical Centre in global surgery and to what extent. So over to you.
Thank you, Andy. I also want to thank you, John and Lars, for the opportunity and privilege to be here today. I think it's important to acknowledge what David just mentioned, that this is a historic day because for the last 35 years, surgery has really not been a part of the global health agenda, and its special thanks goes to Richard Horton and Justine Davies from the Lancet for really helping us now finally, opening that door of public health, just a crack at least. And we've wedged something in there. Now we really need to open that door of public health further and to really be part of the conversations as part of the global health agenda. So again, thank you so much for to all three of the co-commissioners in the Lancet. Again, to many of the individuals in the room who've put a lot of heart and soul into this for a long time. In terms of the role of the Academic Medical Center, Andy, I think it's very important. I think classically we think about academic medical centers, and there's many long-standing partnerships. I think you're going to be highlighting them in your case studies for the Lancet as well, where through knowledge transfer can occur when academic medical centers are partnering with other institutions in the long term. Beyond that, I think there's a specific role as we're focusing today on our high-income countries in terms of developing evidence-based guidelines and protocols and then having them endorsed by international entities. That is something that academic medical centers can have a very specific and distinct role to play. Studying how all of this is going to happen in terms of implementation science, there's a whole field out there. Again, very important as we look to other examples in the public health world, how we are going to do it in surgery. And then I'm reminded, and those are very important things that all of us as academic medical centers can do. But then when you look at the scope and magnitude of the problem that was very nicely laid out by John this morning, as well as others, that's a massive problem. And I'm reminded what Nick Kristof said at the Extreme Affordability Conference last week in Utah, that if you're you need to build a transcontinental highway, you don't raise the money through bake sales. And I think that's exactly the challenge we're facing, although I think the role of academic medical centers is very important. We do have to work as part of the larger surgical ecosystem and global health system as well. It's not just about surgery, it's about surgery as part of universal health care.
Thank you. Robert, your turn. I'd be interested to explore the actual mechanics of how you do this and how you leverage high-income country enthusiasm, talent, interest in global surgery. And I think you, within the program in Rwanda, have really understand the challenges of doing that. So any lessons learned from the mechanics of making it really happen?
Great, thanks, Andy. In my chance to say thanks, I want to reference Dr. Hoyt's comments about the career path. I was a student. Dr. Hoyt was one of my first professors in surgery. John Tarpley, who's on the next panel, is somebody I consider my father in surgery, as my residency program director. And Dr. Gottlieb, to my left, was my first employer at Brigham Women's Hospital. And that leads into my comments, which is we are very much intertwined in our specific career paths as well as what we as academic institutions do. So a brief backstory on the Rwanda program. The Rwanda Human Resources for Health program is a U.S. federally funded program of the Ministry of Health of Rwanda to develop and strengthen the training programs for several cadres, doctors, nurses, hospital managers, and dentists in Rwanda. And the mechanism by which that is done is the Ministry of Health of Rwanda and the University of Rwanda have contracted with a consortium of academic medical centers in the States to bring educational training faculty from our U.S. institutes to Rwanda to partner with the departments there to train trainees, so in medicine that's residents, primarily postgraduates, and to build those programs with the hope that at the end of the 7-year-long process, those departments are strong enough to continue making those human resources gains independent of this external aid. Surgery is one of the sections. Surgery, anesthesia, and obstetrics and gynecology are some of the subsections within the medical cadre of the HRH program. We're 3 years into a 7-year-long program. Some of the lessons learned, I wear a couple hats there. One is a U.S. institutional hat representing Brigham and the Harvard affiliated hospitals, and then a specialty hat representing surgery. And I think some of the lessons learned as we're sort of at a critical mid-course juncture is for the institutions engaging in partnership, the values aligned here are brilliant, right? What do we do as academic medical centers? Well, one of our critical pillars is training personnel to do this work. And that's precisely what the University of Rwanda wants to do, and it's precisely sort of a cornerstone to developing human resources. The institutions, I think we've also learned as we look back, it really is worth taking the time to understand each other, to identify our alignments, identify our common values, to focus on those. We shouldn't necessarily assume that we want the same things until we've actually talked about them. And that can go to what the recruitment strategy looks like, what our budgets should look like, what salaries look like, but also what are the goals of the program? Who are we training and to what end, and what is the output, what is the goal for their careers, the people we're training up. We're in the other hat, and we're in going back to this interlocking institutional goals with individual career paths. For those here, those in the audience, those of us who want to do this work, whatever you might define that work as, there's a certain set of values that I think you need to identify before you engage in the work. And maybe it's not so much values as it is behaviors, but that goes back to Dr. Roy's comments that I'll come back to later, of accompaniment, of walking alongside. You're not coming with your own curriculum, you're coming with an openness to find out what the local goals are. Things probably aren't going to move as fast as you'd like, and that's okay, because when I came to Brigham Women's Hospital, things didn't necessarily move as fast as I liked.
Careful.
And I'm being careful. So humility, I think, is probably the single most important behavior we can express as we enter our relationships.
Great, thank you. I remember once someone saying they were in Uganda and they were going along and there was a sort of bridge and it said, it should have said go slow, but the S had fallen off and it was go low, and that idea of being humble in our interactions with colleagues everywhere, I guess. Gary, you've headed up the biggest healthcare organization in this state. You now head up or senior role in Partners in Health. So can you advise us and bring some wisdom on how to build sustainable bridges between the high income setting and the different setting, low resource setting, urban to rural, perhaps high technology to less technology? How do you make it happen? What are the successes? What are the secrets?
Well, first, I just want to reiterate just how important this landmark report is, and that the timing could not be better. From the notion of the American academic health system, this is a moment of rethinking and transformation in the context of thinking about new payment mechanisms and different resources in order to enable really moving from an illness care system in this country to a healthcare system more reflective of some of the European countries and Great Britain. And in that regard, surgery plays a critical role, and instead of being threatened, is in fact one of the greatest assets in terms of this transformation. In that regard, academic medical centers and health systems, which, as Rob points out, are a font of humility, and probably the most important asset in this regard, are driven by a mission that's probably 100 or so years old, defined with the juxtaposition of medical schools and health care delivery hospitals, first fostered by Johns Hopkins more than a century or so ago, with the notion that these are fonts of and magnets for exceptional young people to lead in innovation, to try to determine how to bring the best and the brightest people to care for the truly sickest and neediest populations, to use science to inform the way that care is provided, and to essentially use that care to develop science, and constantly to make investments in the highest risk communities that surround them. And there is a tension because of the way that those organizations have been developed here in this country. There's a maldistribution of some of that greatest talent into a core resources where rural environments here in this country don't have access to that same skill level. The opportunity on the global health side, which I think has been embodied by small programs like the relationship between the global health programs here and Partners in Health and those that exist elsewhere, have been enabled by exceptional young people who've been driven to try to create change and to try to enable that change. And that is a critical aspect of being able to drive these pieces forward. Without embracing those young people, we won't continue to have the talent base that's driven the great success in academic medicine here and in Europe, without essentially making the partnerships that are necessary in resource-poor environments, we won't continue to attract them. I think the most successful opportunities are all around persistence and continued commitment. As Rob pointed out, understanding through accompaniment what the needs are locally, trying to fulfill those needs over a patient and persistent process, not just sourcing amazing surgeons to visit, not making this a hobby in which small amounts of time are committed, but having a long-range plan that the leadership of academic surgery here in this country and in Europe and England partner together with the leadership from ministries of health throughout the world to understand how to build the pipeline, how to sustain that pipeline, and how to reinforce it. Additionally, opening the eyes of the regulatory environment here so that we can enable visitation on a consistent basis, dealing with both the insurance issues as well as licensure issues for those who are trained in resource-poor environments to both be able to see what works in this infrastructure and what doesn't, and understand that knowledge transfer is continuously bilateral. Academic medical centers and academic health systems are all about innovation. Innovation is not necessarily about high-cost investment, and we won't survive in the current environments if it's all about high-cost investment and highly capitalized infrastructure. It's going to be about learning from folks who are, in fact, in lower resource environments, how innovations in those places enable essentially the growth of intervention and the growth of being able to develop resources. So I think it's multifaceted. One, essentially an understanding that this is a long-range investment, that the next 15 years are going to be critical, that building health systems have to be multifaceted, so they can't be built just around communicable diseases. They have to be built with all the infrastructure that's necessary to be able to provide the resources that John described, as well as mental health resources at a personal level, and to be able to consistently work and understand what the needs are with local government, local ministries of health, and the local leadership, so that we can be much more flexible than we have up until now. And not just to be satisfied transferring a little bit of knowledge or a little bit of skill in dollops over a period of time, but understand that we're going to need to be able to build foundations and build on those foundations in order to have sustainable outcomes.
Brilliant, thank you. Let's just acknowledge that. And that was... There was a richness there in that analysis from all four panelists, so thank you. Right, now we're opening it up, so it's your chance. So if you want to ask a question, perhaps just for the sake of everyone else, say your name and your institution, and then fire. Eileen, appropriate to start with the founder of Global Surgery, so Eileen.
Thank you. Thank you very much. This has been an enlightening discussion. I want to address a very specific issue that I think could make a major contribution to global surgery in the developing world. And that is the care of trauma. Trauma kills some 3 million people a year. It's incredibly, it's an incredible drag on the economy of the countries. The American College, through its Committee on Trauma, is arguably the best equipped to deal with developing trauma training programs and trauma systems. I'm wondering how we can accelerate or how we can bring about a role for the American College to help ministries of health in developing countries develop trauma care systems.
Great, thank you, Heidi. We will take other questions in sort of packs of 2 or 3, but to start with, let's just address that question. David, do you want to?
Well, I think, as I look at the metrics from this report, to put a number on what Hailey just said, I'd say about a third of this burden is probably trauma care related. And some of it is access. Charlie Mock has worked a lot on this over the last decade or so. What the college is willing and prepared to do is to offer the resources that we've developed in the Committee on Trauma, which include how to set up a pre-hospital system, how to do that in a more constrained environment, how to teach pre-hospital providers to decrease one of those delays that John referred to. I think initial resuscitation, we have a prototype that's been pretty well tested throughout the world and is transferable to underserved countries in terms of the language that it provides and the basic training that's needed. And I think, that's also available to be used. There are actually some versions that have already been created that try and simplify it for resource-poor environments if you don't have intubation, for instance, available or some very specific things. But I think, we've also done some substantial fundraising to try and support just that. So we would love to create additional partnership opportunities to try and promote trauma care in this world.
Thank you. Other questions?
Good morning. I am Lori Romanzi. I am Project Director of Fistula Care Plus. How are you? For Engender Health. And in my pre-directorship phase, I had the opportunity to fish with many of our colleagues, including in Rwanda at Human Resources for Health. So with regards to training, I would like to drill down on a very specific issue that I've seen in many regions of the world that underpins any attempt or would undermine any attempt to improve healthcare training. And that is the fact that in many places, medical students are sent directly after medical school out into remote regions to provide care of all manner, including emergency surgical care, including the trifecta of surgical cases that we are talking about here today: fractures, laparotomies, cesarean section. What is the perspective of this commission with regard to that, and also in regard to the lack of perioperative morbidity as one of the indicators that are under consideration? Specific circumstance that we see all the time in obstetrics is cesarean section and other obstetric emergency procedures contributing significantly to the iatrogenic genital fistula issue. It's a huge epidemic in the making. Thank you.
Okay, thank you. Let's have a few more questions. The middle at the back, sir. Yep.
Thank you. I'm Henry Rice from Duke University. I too want to thank the Commission for elevating the language and in applying metrics that will help all of us who are interested in global surgery really move forward. I want to follow up on Fizan's analogy of a bakery sale, though, and I'd love thoughts from the panel and the Commission on ways to transform or ways to engage major funding agencies into support of this work, which has been a real stumbling block. You know, it's often said there is not a parallel global fund for surgery, and yet the need demands it. So let me pose that, maybe Fizan and the rest. How do we tackle that?
Okay, that is going to come up this afternoon, the afternoon session, but we'll allow the panel to address that one. Thank you. Yeah, I have two more questions, and then we'll turn to the panel. Yes, sir.
My name is Gurma Tafara. I'm the new director from Operation Giving Back at the American College of Surgeons. I have two questions for the panelists. One is, you know, we don't really talk a lot about what do we get out of all this, and what do we, in a sense, I mean, the developed world. And I think the narrative has to address that a little bit more so that, you know, our policymakers can really understand why do we want to do this. And the second thing I just want to raise is about academic institutions. There is basically a lot of things that are being done in a way that we are not joining forces. What are your thoughts? How can we join forces to be a little bit more effective and efficient? Because we're spread all over the world. And is that really the way we should do this when things are pointing to where the needs are? So these are my two brief questions.
Thank you. And we have one more question.
Hi. I'm Sarah Feldman, GYN oncologist here in Boston at the Brigham, and I just want to thank, this is personally and professionally very wonderful, and I appreciate it. But I have two comments. One is as a patient. As some of you know, when I broke my leg in Rwanda 2 years ago, I had direct experience with trauma in Rwanda. After the several-hour car ride that Partners in Health arranged for me that no Rwandan could have had, I was able to go to the main hospital in Kigali, where I did get an x-ray, had a very complicated fracture that could not be repaired in Rwanda, so I had a large cast placed. No pain meds, no heparin, no crutches. So when I arrived back in the United States several days later with a repair of something that could never have happened in Rwanda, with multiple clots and without pain meds and all those types of things, I couldn't help but think about what one of the ladies in the airport, one of the elderly ladies in the airport in Rwanda said to me, "You're going to die. You will never survive this." But after that repair in the United States, I came back to work and I'm fine. But there's nobody in Rwanda who could have survived that because of no care, no access to get there, no pain meds, no crutches. They could never have gone back to work. So it's a very complicated issue, but I think it's more than just what we can do surgically. So that's just the first thing, is just getting to the hospital and having basic things like pain meds. We can't do surgery without pain meds. So that's just my personal profound issue that I hope we get crutches and pain meds in all these countries. But on a different level, I'm an OBGYN by training, but a GYN oncologist, and we've struggled, Tom and I, dealing with how do you do surgery in places where the people who have been trained, as you said, one of these ladies said, are just people who come out of medical school. They maybe could do a C-section, or maybe they're an OBGYN, but they really cannot do radical pelvic surgery, which can cure people and is one of the #1 causes of cancer death or death worldwide, cervical cancer. And we have struggled at our national meetings because I suggest, why can't we actually partner with our general surgery colleagues? Why are we training OBGYNs who don't have the skills to deal with this? Why not partner with our trauma surgeons to say, Could you do the surgery for us? Can we treat, because we can train a trauma surgeon to do a pelvic lymphadenectomy, but we can't train an OBGYN in some of these places to do it. So my question goes also to Gary with the history of medicine. We have silos, OBGYNs, primary care, surgery. But we have people in these countries, and we want the people with the best skills to save these lives. And that may be general surgeons for my field, not OBGYNs. But we're not able, because when I suggested to Rwandans that we talk to you and have trauma surgery get involved with us, because there's no way after we try, that's what I was doing, trying to train them, and it was like, no possible way can we do this. We cannot do this, it cannot be safe. The OBGYNs there cannot do it. I was met with a lot of resistance because the history of medicine is OBGYNs over here, GYN oncology goes in OBGYN, but we have general surgery where we need your skills. We need your skills to save the lives of women, fistulas, all sorts of things, hemorrhage after OB care, all of this we need general surgeons. So we need to get rid of the silos and partner. So thank you.
Okay, thank you. As you answer some of those questions, there's quite a lot, you've been pushed quite far there, but perhaps particularly reflect on why are we doing this and the role of co-development and also the boundaries that the colleges or the academic medical centers should put around. I mean, you're not there to solve all the problems of global surgery. There are many other implementators, particularly in the lower middle income countries themselves. So perhaps as you answer those questions, perhaps reflect on the issue of co-development, why we're doing this, and the boundaries around. So who wants to start off trying to address some of those questions? Fizan.
So I want to thank the several questioners for very interesting questions. I'll begin by reflecting on the trauma issue. I'll come back to that in terms of what colleges might offer. I think some of the most important elements of the Lancet Commission report is the analysis and resources as it relates to national surgical systems. And I think the American College of Surgeons, as Dr. Hoyt mentioned, has a vast experience to develop trauma systems, and they have a beautiful optimization document that, for example, we in children's surgery have now used it to set up different levels of care and stratify care and develop systems and actually really reorganize systems. It's actually having an impact in the U.S. healthcare system in terms of reorganizing the healthcare system as it relates to the delivery of the surgical care of children. That experience, that real-life experience from the college would be very important for us as we think about developing stratified systems globally. I want to thank Kate from the Fistula Foundation for her question as it relates to medical students. You know, from Lars' comment about task sharing, I think it's really important. I think everyone would agree that the decisions about the scope of practice are very much a local decision, and that's not something that we would ever make a decision about here. And I can, you know, putting on my American Board of Surgery and program director hat, I see a fellow program director in the back row, Dr. Schamberger, as well. We just discussed it last week that we don't endorse, not only not medical students, we don't even endorse, just to answer your question directly, residents going without having appropriate supervision. And there's very strict rules that the American Board of Surgery in cooperation with the Surgery RRC have come up with, and they're actually being negotiated right now to see which type of cases would count, et cetera. But the bottom line is no one would endorse a medical student to go on their own. And then the last issue of funding. You know, when you go to funders and you ask for a global fund in surgery, I think it's really important for us to ask. That's where John's point comes back to what it comes back to in terms of what the commission is providing. Is we really have a robust set of indicators, because at the end of the day, funders want to know, what are we paying for? And that leads us into the next part of the discussion, which is, if you look at other global health movements, what is the global action plan for surgery? And that's where the G4 Alliance, you guys may have heard about that referenced earlier. If you haven't, look it up. That's where that will come into play in terms of the advocacy piece, as well as a global action plan for surgery.
I think, you know, my final comment would be really what is the most important thing I can think about today in this report. And I think this is a call to action to accept responsibility for this problem. I don't think that in our college we have done that until now. I think we have changed significantly in the last 2 to 3 years. But I think this will accelerate that. And I would actually invite John to come and present this to the Board of Regents. I think we need to increase people's education about this with an eye toward really trying to create responsibility within the United States, globally as well, but within the organization that I have responsibility for, to create a sense of responsibility. And from that, then, I think a lot of these problems will be solved. When we started trauma systems 40 years ago, we didn't ask them about the money. We really didn't. We just did it. And we figured it out, and we figured out the money after that. And I think, we do have to worry about the money, but I think what we really have to do is to commit and take the responsibility to solve the problem, and the money will flow.
This report is a catalyst that answers several of the questions we need to deal with the dysfunction that we have that's created turf battles and silos that have caused us not to collaborate to solve massive problems. We now are faced, and there's evidence from this magnificent commission report that there's a massive problem that's symptomatic of an absence of health system strengthening overall, and that the task has to be around health system strengthening. And therefore, surgery, its sister disciplines need to be at the table with those who build health systems, with those ministries of health, in identifying solutions that allow us to go the long run. Because if we focus on individual disciplines or on individual surgical problems or on funding in single streams just for surgery in the absence of non-communicable other diseases, or just in surgery without building out the rest of the infrastructure that's necessary, which ultimately here is going to include housing security, food security, water security, and roads in order to meet the criteria that we described, will fail. And we'll find fragmentary solutions, small victories, and very, very angry partners who are still living in very, very difficult circumstances. This is a long-run solution that's going to mean that we're going to have to be patient. We're going to have Paul yelling at us every other year about how we've been inadequate in this regard, and still keeping our heads up and driving towards that interdisciplinary and professional set of solutions in order to be able to manage this.
Very good. Robert.
I'd just like to address Laura Romani's comments on the new medical students in district hospitals and the trainees. I think this is a question which leads to the importance of understanding our context. So this is a real question in Rwanda now. There's a real trade-off between the population health goals of decentralizing care, i.e. getting some partially trained providers to the places where people live, and the training goals of building up the human resources. So the one needs doctors, hopefully somewhat trained, and nurses and other healthcare cadres in the district hospitals. The other needs a critical mass of trainers in the central hospitals, but you only have a few people to go around. And so we as partners need to understand that tension and we engage in that discussion. I think as an example, when the Human Resources of Health program in Rwanda was launched, the district hospitals, most people don't know this, were emptied of their primary providers, and they all came to Kigali, and our district hospital colleagues were not particularly pleased with the program. And so what happened, they got backfilled with even more junior medical students. So there's an avalanche effect there that hopefully will get turned around in about 5 years as people are turned out a more finished product and returned in some way, not using people as commodities, to provincial and disseminated spaces. In the end, I think this leads us back to Dr. Roy's comments about fishing, which for me, was my single most favorite moment of all last week in the London launch of the Lancet. And I'll just remind you, he said, it's not so much about not giving man a fish and rather teaching him to fish, but let's go fishing together. And I think his message there, and the message we should carry, is that what does it take to go fishing together? You got to set up your tackle box, you got to walk to the river, you got to understand the river, you got to bait your line, you've got to spend some time with your co-fishermen, you got to walk back to the village. And in doing so, you'll hopefully get to know the river a little bit, know something about your fish, learn to trust your fishing partner, and maybe down the road, you'll catch some more fish, and you'll feed the village, and you might be able to start counting how many fish you caught, and hopefully be able to mark an uptick in the fishing production line. But if you don't have that trust of fishing that fishing together brings, the metrics you're going to pull out from the end of it aren't really going to be reliable.
Thank you. Gary, did you want to
But
add?
just to that, tangentially, our avarice and our own desire to have skill here has caused a substantial amount of that drain brain, and therefore caused, to some extent, local authorities to create sub-threshold training so that people have a set of skills to fulfill a set of needs, but not adequately specialized needs to be of interest to be recruited outside of the country. And our accompaniment means also creating sustainable economic development simultaneously. We pretty much know how to use hospitals and academic medical centers to build employment base, to create sustaining economic development in a variety of venues. We need to party locally to be able to make certain that that happens, and that the venues that people work in are adequately attractive to sustain them over the long run, and to attract young people of higher skill to remain in those venues, whether they're rural or urban.
Fizan, David, Robert, Gary, thank you very much. We got off to a great start. It's coffee time now, and we want you back here at 10:15. Sorry? 10:50. Oh, that's going to be really difficult, yeah. 10:50. Okay.